Good afternoon, all. A warm welcome from Department of C.T.V.S. AIIMS, New Delhi. We would like to discuss one of the rare cases so far reported, which we operated successfully with the team approach and team coordination. It's a wonderful anatomopathological discussion. Hope it will create. Now I'll invite Dr. Amitabh Satsangi to start the presentation.
Good afternoon, respected faculty and my dear colleagues. So today we'll be discussing a rare case that involves a 5-year-old school-going boy which presented with an increased precordial activity and failure to thrive. There was no history of recurrent lower respiratory tract infection or feeding difficulty in infants. The perinatal history and family history were not significant, and their developmental milestones for age were not. On clinical feature, there was a facial dysmorphism that was seen with a prominent forehead, depressed nasal bridge, hypertaylorism, and short neck. For weight was 12.6 kgs and height was 98 centimeters, both lying in the Z-score minus. On examination, it was found that the pulse was high volume and all peripheral pulses were well palpable. The heart rate was 90 beats per minute, and the blood pressure, which was taken in right arm supine position, was 108 by 56 mmHg, with the saturation at room air, oxygen saturation at room air was 100%. On cardiac examination, the apex beat was on the left sixth intercostal space at the anterior axillary line and was hyperdynamic in nature. On auscultation, we found that the first heart sound was normal and the second heart sound had a narrow split with a loud pulmonary component, and the S3 at the LV region was also positive. A murmur was found that was a continuous murmur at the left infraclavicular area, and the mid diastolic murmur at the apex was found. The respiratory system, the CNS system, and the abdominal examinations were within normal limits. On further investigation, the chest X-ray revealed that there was a cardiomegaly with the cardiothoracic ratio of being 0.65 or 65%. There was pulmonary plethora that was evident, and the superior mediastinum was widened. ECG revealed a normal sinus rhythm with a rate being 130 beats per minute. The axis was normal with plus 30, and there was a biventricular hypertrophy that could be seen in V2 and V3 leads. So the clinical diagnosis, as per we found, was that it was an acyanotic congenital heart disease, most probably due to an increased QP because of the X-ray finding and the findings on ECG, and the diagnosis was thought to be of a large PDA. Then again, an echocardiography was performed later on, which will be discussed by my colleague Dr. Shatanik Sarkar.
Thank you, Dr. Amitabh. Good afternoon, my respected teachers and my dear colleagues. This case with 5-year-old boy with a clinical provisional diagnosis of large PDA, which is a cyanotic congenital heart disease with increased pulmonary blood flow. So we went ahead with the echocardiography. In the first left-hand side picture, we are seeing the apical fourth chamber view, where we are seeing that there is a dilated left atrium and left ventricle, which is a usual finding in any post-tricuspid left to right shunts. And in the right hand side picture, we are seeing the parasternal short axis view, where the aortic cross section along with the RVOT in the main pulmonary artery with its branches. The branch pulmonary arteries are confluent, but there is a flow into the pulmonary artery, which is seen as the red color into the pulmonary artery. But it is not at the usual position where ductal flow is seen in the pulmonary artery. So it was something unusual flow into the pulmonary artery, which is to be evaluated further. So next we went ahead with the arch view, suprasternal arch view, where the specific thing which we have noted that the complete arch, which is usually delineated in a single view, but in this case the complete arch was not delineated in a single view. That is, the ascending aorta and arch and descending aorta was not seemed to be continuous with each other in this view. And also, but the possibility of any arch interruption or coarctation could be there. So, but the descending out of flow was continuous without any evidence of any coarctation or interruption. So there is always we thought of a possibility of some aortic arch anomaly. So next in the ductal view, in high parasternal view, where usually we find the ductal flow that is flowing from aorta to pulmonary artery, but in this case we were not able to find any ductal flow into the pulmonary artery by any chance, by any view. We were not able to delineate the ductus. So with echocardiography, we have some unanswered questions which needs to be answered, that what is the arch anatomy, whether we are dealing with some kind of arch anomaly, and whether there is any vascular ring which is commonly associated with arch anomalies, and what is the exact source of the left to right shunt which was also found clinically and also in the echocardiography into the pulmonary artery, but it was not at the usual location. So whether it is a duct which is unusually located or whether it is something else. With these unanswered questions, we went ahead with the CT angiogram, which will be discussed by Dr. Mansi from cardiac radiology.
So, thereafter, CT angiogram was performed for this patient. So I'm just coming to the main anomaly which was present in this case. So we can see that this arch, the aortic arch, was present to the right of the trachea, suggestive of a right-sided arch. And then this aortic arch was crossing from right side to the left side at the tracheal level, suggestive of a right-sided circumflex aortic arch. If we see, I'll also demonstrate in the VRT images for better depiction, but firstly scrolling through the axial images. So we can see that from the right-sided arch, the vessels which were arising was a right-sided subclavian artery, the right-sided common carotid artery, and there was an aberrant left subclavian artery which was arising via the, via the commurals divertically. But there was another aortic arch branch. This was actually the left common carotid artery which was arising from the main pulmonary artery which was dilated, and also all the right as well as the left pulmonary artery was dilated. So if I move more cranially, we can see that this vessel which was arising from the main pulmonary artery, it was actually the left common carotid artery. So there was isolation of the left common carotid artery and it was arising from the main pulmonary artery. And also the right sided coronary artery, it was arising from the base of this left common carotid artery. And as already depicted, the left atrium and the left ventricle were enlarged. Yeah, sorry for the interruption. So just so it is better depicted on the volume rendered images. So this we can see, this is the ascending aorta and the first branch is the right common carotid artery, and thereafter the right subclavian artery and the left common carotid artery. It is isolated and there is origin of the left common carotid artery from the main pulmonary artery, and the right common carotid artery is arising from the base of this left common carotid artery. And also there was aberrant left subclavian artery which was arising from this right-sided circumflex arch. Now I invite.
So as of now, the CT angiogram almost depicted the whole anatomy, and it was almost clear to us with we were dealing with. But still, we went ahead with the cardiac catheterization with the following things in mind. First of all, the hemodynamic data acquisition. We wanted to acquire the hemodynamic data to know the PA pressure and also to better delineate the coronary anatomy and whether there is adequate collateral circulation is there, as RCA was filling from pulmonary artery. So actually it was retrograde flow through the pulmonary artery. And also, as this was a case of unusual anatomy, from academic point of view also we wanted to record the catheterization data. So first of all, this is a aortic root angiogram, which is the injection is dye is given into the aortic root, and the whole of the aorta, ascending aorta, arch of aorta, and descending aorta are opacified. And here we can see the all the branching patterns of the arch of aorta. So first of all, we are here clearly see that the aortic ascending aorta is ascending in the right side of the midline. So it is a right-sided aortic arch with left descent. So it is a right circumflex aortic arch, which is also given in the CT angiogram. And the branch vessels will be better delineated in a still picture. It will be better understandable in the still frames. So I have kept those still frames also. So first branch, which here we are seeing that the first left hand side picture, the first branch is right common carotid artery, the second branch is right subclavian artery, and the third branch is down here, the aberrant left subclavian artery, and the left common carotid artery is not seen to be arising from the arch of aorta or descending aorta. So in the next phase also it is clear that the left subclavian, aberrant left subclavian artery is there, and in the levo phase, that is in the delayed phase of the angiogram, we could see some vessel coming from above downwards, which is going into the pulmonary artery. So this is our left common carotid artery, which is actually filling from the above downwards. There is retrograde flow in the left common carotid artery because pulmonary artery is a low pressure artery. So actually the left side of brain is filling from the collateral circulation from the right common carotid artery only, and the direction of flow in the left common carotid artery is reverse. And in the left coronary angiogram, we can see that the injection into the LCA, left main coronary artery, is filling the RCA through collateral circulation, which is also seen in the lateral view, that the left main coronary artery injection to the collateral circulation, it is filling the right coronary artery, which is inserted into the PA. So about the results of catheterization data, there is a significant step up of saturation from RV to PA, which suggests a left to right shunt at the arterial level, and also the PA pressure were measured at 45/30, and the QP/QS ratio was 1.7, which was also suggestive of a left to right shunt. So I am inviting Dr. Amitabh to finish the.
Thank you, Dr. Shatanik and Dr. Mansi. So, with the help of our colleagues and our teamwork, we reached to a final diagnosis that we were dealing with the right circumflex aortic arch, an isolated left common carotid artery connected to the pulmonary artery, aberrant left subclavian artery, an anomalous origin of the right coronary artery from the base of the left common carotid artery, and normal biventricular function. So, after a challenging diagnosis, now we come with the challenge of how to deal with such an issue. Initially, there was a delay in surgery due to the ongoing COVID-19 lockdown, and patient also developed an asymptomatic COVID-19 infection in August 2020. So the management options in our hand were mostly surgical options, and we had to choose that either we have to re-implant this isolated left common carotid artery into the ascending aorta, or we have to ligate this isolated left common carotid artery. And the second option we have, second thing that we had to do was a reimplantation of the right coronary artery versus ligation of the right coronary artery. The data that we had assembled from the coronary angiogram and the CAT study, we knew that the right coronary artery was being supplied from the left coronary artery due to the collateral circulation. And second thing was that we knew from the MRI brain that we had performed preoperatively that the circle of Willis was intact in this. We knew that the circulation in the cerebral circulation was also intact. So our management plan was other thing was that whether to go on a cardiopulmonary bypass machine or not. Plan that we made was initially we went in the operation theater with the plan of a reimplantation of the left common carotid artery to the ascending aorta to re-establish the cerebral circulation from all the arch vessels, and then reimplantation of the right coronary artery from the pulmonary artery to the aorta. So the pre-surgical evaluation, as we talked about, as there was a cerebral steal, the perfusion characteristics of the brain were not known, and we did an MRI brain which showed us a bilateral normal cerebral parenchyma and a complete circle of Willis. So the surgery that we chose was for an off-pump surgery in which the patient was not put on a cardiopulmonary bypass machine, and a midline sternotomy approach was used, and a continuous near-infrared spectroscopy monitoring was done for the brain perfusion. The left common carotid artery was disconnected from the pulmonary artery and implanted on the ascending aorta. And during the dissection of the left carotid artery, common carotid artery, we found that the right coronary artery was very thin, fragile, and retrogradely filling, as we knew from our previous scans, by the collaterals from the left coronary artery. And a limited course over a right ventricle was also noted. So, hence, during the procedure, it was ligated and sacrificed. So for a better pictorial representation, as we can see, this is the intraoperative photo that you can see. So this is the ascending aorta. This was a thin right coronary artery, see? And this was the pulmonary artery, dilated pulmonary artery, with the left common carotid artery, which was originating from the pulmonary artery, and the right coronary artery originating from the base of this left common carotid artery or the pulmonary artery. This is the pictorial representation. As you can see, this is our ascending aorta. These are the arch vessels, and this was the pulmonary artery, which was giving origin to the left common carotid artery and the right coronary artery. After the surgery was performed, we were able to connect the left common carotid artery anastomose to the ascending aorta, and the right coronary artery was clipped, and the pulmonary artery, the defect that was creating after the reimplantation, was repaired. So this was our final image, which is close to a normal anatomy. That is, all the arch vessels are taking origin from the ascending aorta, and the right coronary artery was clipped. Since it was being supplied from the left coronary artery, the entire system was intact. So,
Hi everyone, I am Dr. Sudhir Arava.
so the histological confirmation of the tissue was required. So, Dr. Sudhir Arva will be
From
online.
the
So he'll
Department of Pathology. So in this particular case, we have received a small fragment of vascular tissue for histopathological confirmation, and the difficulty being that whether the excess tissue is of left common carotid artery or it is a ductal tissue. We process the specimen, and in picture A, all of you can see that it is a microscopic picture of the same vascular segment. Here we have an endothelial lining, and this vascular segment has got thick smooth muscle media. These are all medial smooth muscle cells arranged in a particular fashion. It has got thick media, and we did carried out some special stains. And first one was Alcian blue mass stain, which highlights that medial degeneration and accumulation of proteoglycans. It was not there in this case. And picture C, what you're seeing is another special stains called as Verhoef's Van Giesen stain, which is done to highlight the elastic lamellae or elastic fibers. So in this pictures, the arrow itself shows that the blackish colored wavy fibers, what you're seeing, it is the medial elastic fibers, and this is the medial elastic lamellae. So this muscular arterial segment has got normal or well preserved elastic media. With these histological features, and we can conclude that the vascular segment which has been excised has got thick muscular smooth muscle media with a well preserved elastic medial elastic lamellae, which confirms that it is elastic artery, not a ductal tissue. So usually in ductal tissue, if you see under microscopy with the special stains, you will not see this kind of elastic lamellae. It will be very sparse. Hence the final opinion from histopathology is an elastic artery. Thank you. Hi everyone.
Yes, sir. It actually pre-recorded this. He had so David's. Uh, during the ICU course, initially the patient had a smooth immediate ICU course. It was an uneventful extubation within 4 hours. The sodium nitroprusside and NTG infusion for blood pressure control were initiated. Post-op day 2, patient was started off oral enalapril, metoprolol, and oral nitrates were initiated. And post-op day 3, tapering of infusions was started as BP was well controlled. Then on the post-op day 4, the patient started deteriorating, started developing a mild puffiness on the left side of the face, and over 24 hours, swelling worsened and became painful with local rise of temperature. The projectile vomiting with drowsiness was present, and BP was above 99 percentile, and left lateral rectus palsy, and on fundus examination, papilloedema was seen. So an NCCT brain was done, and it showed us that there was cerebral edema that was seen, and later on echocardiography was also performed, and it showed us that there was a moderate LV dysfunction, normal RV function, and mild bilateral pleural effusion. So the cause was said to be basically an hypertensive emergency that had occurred, and it was urgently shifted to a CP6 of pediatric cardiology ward, and the patient was managed by them with a 3% saline started for the raised ICT, multiple antihypertensives given, like SNP, then shifted to labetalol, and then right-sided focal seizures. They had an episode after 12 hours for which Levera was given. Then SNP was gradually tapered off and NTG was started, and there was a partial blood pressure control attained, but still remained in the 99th percentile. The 99th percentile. So, what was the initial cause? The entity was diagnosed as being a cerebral hyperperfusion syndrome. This generally occurs after a carotid endarterectomy or a carotid artery stenting, and it is due to an impaired autoregulation or a baroreceptor dysfunction, NO and free radical mediated blood-brain barrier dysfunction that occurs. So the patient was started on oral clonidine and gave a very good response, and the blood pressure was controlled and facial edema disappeared. So for MR angiography, I would like to call upon Dr. Mansi Verma to explain a few slides.
This was the MR angiography which was done for this patient, and I'll be showing the non-contrast images. Here we can, this was the pre-operative MR, and this is the MR which was done on the post-operative day 11. And as compared to the pre-operative MR, now we could see that there was presence of hyperintensity which was seen on the FLAIR images, and this hyperintensity was seen in the left occipital region and also predominantly involving the white matter. And also a section which was taken more cranially, we can see that again there was presence of hyperintensity which was present in the left frontoparietal region, predominantly involving the white matter. However, on the T1 weighted images, there was no abnormality, there was no diffusion restriction, there was no presence of any hemorrhage. So, considering the findings of this hyperintensity which was seen on the T2 FLAIR images, predominantly involving the white matter, so we gave a provisional diagnosis of cerebral hyperperfusion syndrome. Yes, sir. Yeah, yes, sir. Actually, there is presence of cerebral edema, sir, and there is presence of hyperintensity in the. Or it's a smaller. No, sir. Actually, act, sir is saying small in, means small in size, sir. It is swollen, but sir is saying the size is small. Yes, sir. Yes, sir. That is what. Yes, sir.
So after a successful management by a team approach, then the patient was successfully discharged on the post-operative day 14 with oral medications like furosemide, metoprolol, clonidine, aspirin, and oral Levera. And on follow-up, the blood pressures were in between the range of 50th to 90th percentile. And after 1 month, the ACE inhibitors were started, and 11th month, the left ventricular ejection fraction was 60, normal biventricular function. And this is the echocardiogram of the last follow-up, which shows a normal size of all the ventricles were normal compared to earlier, and a normal function. So this is the case that we had. Anybody would like to ask any question, because the discussions are based on embryology, and I don't think so that we'll discuss. Yes. So now the rarity of the case is that only this is the 10th case that we're going to report. Only 9 cases have been reported with such an anomaly in the past literature. This is the whole literature of all the cases that are there, total of 9. Most of the cases had some anomalies of the congenital heart anomalies. Yes, sir. Questions? First from India, that knows one more case has been reported from Sri Chitra, but that is a little bit different. It is an internal carotid artery that is arising from the pulmonary artery, not the left common carotid artery. But it has been reported from Sri Chitra, one case. But the case with the similar coronary anomaly and this is not reported. Would be first one. So now the take-home message was that this is an unusual location of a left to right shunt. Usually we think of a PDA that is present or an AP window, but this is a unusual location of a left to right shunt at a great artery level. You can suspect an arch vessel anomaly. The CT angiography is the best modality for arch evaluation. The multidisciplinary team approach is for the best management, and the experience from the previous similar case helped to detect and manage the worsening well in time. And in the next case, the deterioration can be anticipated and prevented further. Thank you, Professor.
How do you prevent cerebral hyperperfusion? Are there any modalities to early diagnose and prevent it happening?
Right now, there are no uh, modalities described for the prevention, sir, but anticipate and manage with the pharmacological management. Because long back we came across with one similar case. So we had a troublesome post-operative course in that case. So with that experience and with the help of neuroradiology, Dr. Levi Joseph, so we are able to optimize. We anticipated this in on day 4. So electively we manage with the antihypertensives so that pharmacological management will be proper to let the left carotid chemoreceptors take time to adapt for the regulation of the blood pressure. And so we waited for that time. That time we optimized it. Right now there is no literature.
And we lost almost like 36 hours when the child had hypertension. And from the literature review, then we realized that clonidine is something which is very, very useful. And as soon as we started it, within 12 hours, almost everything started settling. And next 36 hours, we were right there where we started. So I think from all this, what we learned was that although we anticipated everything, but our drug choice in the beginning was not so appropriate.
You required a centrally mediated drug, basically.
Yes, sir. Yes, sir. So initially we were trying to reduce the using vasodilating agents like NTG and SNP. Actually, they were probably counterproductive in this situation. So we initially aggravated the problem rather than relieving it. But as soon as we realized and we started clonidine, we were back on track. And fortunately, everything got reversed very soon. We went to like LVF of 35%. Patient was really sick at that time, but within a matter of 12 to 14 hours, we were back. And right now, child is good. Is requiring still 2 antihypertensive medications, and we are being more cautious in controlling hypertension.
Any cause of unilateral neck edema in this patient?
That is what is described, sir, in unilateral hyperperfusion syndrome. Sir. The clinical picture actually typically fits into that.
The flow is opened up, so that's why the face on one side is.
So just one question. Physiologically, this carotid is not connected from birth. So is the left brain receiving less blood? Only then hyperperfusion could occur. That means the connecting KY is not good enough, or it happens like this only. Yeah. But so in effect, the left side is getting less blood than what it should have normally got, isn't it? That's why they get into this. Once you restore the supply, they are not able to put the normal.
But something similar is
But then,
But we,
but future it will be one carotid system rather than two carotid system now.
actually, I think that patient was possibly a little older also. This patient is relatively younger. So whether that makes a difference.
No, same age group. Same age.
But similar hyperperfusion is described after carotid artery stenting also. So it is not a matter of congenital versus non-congenital. It is possibly related to the duration for which it has not received a blood. Maybe.
Dr. Saurabh,
But I know. So from our own experience, like here also we managed BP low, but our choice of agents were different. So do we think that starting clonidine right in the post-op period would have avoided?
I mean,
Yes.
can it be started prophylactically in
Yes.
in such cases?
I mean, that probably is the lesson from.
Okay. Okay. Ah,
So here it won't be possible, I guess.
actually, this carotid artery was dangerous to handle. Actually,
It's
it was
very
scary
fragile
situation
and
on
thin wall.
table for us. Actually, it is very thin. It's a very thin wall. They have used the finest suture. Even with that, also it is getting torn off.
So it got converted into characteristics of like pulmonary artery, a
Ah.
thin wall artery.